Good afternoon. I'm Dr. Eugene Heslin, and I'm pleased to be the moderator presenting today for monkeypox vaccination and the care of adolescents, access and best practices. Today, presenting for the New York State Department of Health will be Abigail Guzband, a special assistant to the commissioner, and she's been involved with the monkeypox response through the Office of the Commissioner since the beginning of this crisis. For New York City Department of Health, Dr. Marion Larkin, who is the Assistant Medical Director and High School Program Office of School Health for New York City's Department of Health, is presenting. She is a pediatrician with experience working in primary care in a federally qualified healthcare facility. She has worked in the Bronx in school-based programs. She also serves on the executive committee of the American Academy of Pediatrics Council on School Health, and we're so grateful to have her here with her expertise dealing with adolescents and youth. The agenda today is going to be an update on monkeypox outbreak, the designation of monkeypox as a sexually transmitted infection in New York State, best practices for providing care for adolescents, and at the end of every presentation, resources that are available for accessing monkeypox vaccine and care. I would like to thank the participants in this webinar today for their putting together of the slides and this program. As always, these programs will be recorded and available on the New York State website shortly after the presentation is done. Finally, I'd like to thank Michael Wren, our producer of this program. And now I'd turn it over to Ms. Guzband.
Thank you, Dr. Heslin. First, I'll be providing an update on the current monkeypox virus outbreak. For daily cases reported in the United States, we're seeing, and very glad to be seeing, a decline in our curve that began in August and continues throughout October. United States has reported a total of 28,061 cases and 6 deaths. And New York State and New York City together represents about 14.4% of cases diagnosed in the U.S. overall. Again, we are seeing this similar curve for our daily cases reported in New York City and hope to see this decline and tailing off of cases persisting in the next coming months. New York City currently holds the majority of cases for the entire state, with a total of 3,683 reported as of October 24th. For the rest of state, we're also seeing a similar curve, except the daily number of cases are much smaller here per day and overall. The rest of state is reporting a total of 352 cases. So this is about 10% of the total number of cases across the state. The cases that we're seeing here in the state, 2/3 of them are actually located in counties surrounding New York City. So this is where a lot of the spread is going on. So looking at the age and gender of patients with monkeypox, we're primarily seeing spread amongst men who have sex with men. And as you can see here from the dark blue bars, primarily spreading in men. And there's been a limited number of cases reported for women, transgender men and women, and other sex and genders. We're also seeing a limited number of cases in adolescents, which I'll discuss a little later on, and those between the ages of 18 and 25. So most of you probably know this already, but we're seeing monkeypox spread during intimate contact, including but not limited to sexual contact and skin-to-skin contact. To date, sustained transmission hasn't been identified outside of the networks of men who have sex with men, including transgender, gender nonconforming, and non-binary networks. So, as I mentioned previously, there's been a very limited number of cases reported among children in both the state and the city. A total of 5 cases have been reported as of the 20th in the city, and 3 cases have been reported as of the 26th in the state. Also, there have been very few individuals under 18 that have been vaccinated to date. So, why do adolescents encounter barriers to accessing these vaccinations and care? Some of the reasons may be that parents or guardians may not be aware or accepting of their child's risk for monkeypox exposure or their sexual orientation or gender identity. The youth might be avoiding this care rather than engaging in these conversations with their parents and guardians, and they might not know where to get this care without their parents' consent or where or how to get the care. So next I'll be discussing the designation of monkeypox as an STI. In the state, minors under 18 generally can't consent to their own testing without permission from their parent or guardian. The exception are conditions recognized as STIs under the regulations. On October 6th of this year, the Public Health and Health Planning Council did approve the emergency regulation to add monkeypox to the list of STIs recognized in this regulation. And this permits minors to access testing and vaccination without a parent's consent. This regulation is currently in effect until January 4th, but it might be extended or permanently adopted. So, what does this all mean for clinical practice? Sexually active minor adolescents with the ability to make their own medical decisions may consent to their own monkeypox care. And when we say sexually active, we mean it may include anyone at a risk of an STI. Currently, we're recommending the JYNNEOS vaccine, the intradermal administration for those 18 years and over. And we're recommending subcutaneous administration for those 18 years and younger. The vaccination reporting requirements say that all monkeypox vaccinations must be reported to our NYSDOH and SEER systems within 72 hours of being administered. So these systems don't actually flag the vaccines that are consented to by the minor. So the youth should really be aware that at any time, a parent or guardian, by request, can obtain these reports that would disclose a vaccine that that child obtained confidentially. Dr. Larkin, what do you think about these changes to the regulations and the opportunities it provides for children under 18?
Hi, thanks, Ms. Guzman. I think this is a great opportunity for young people to be able to access care and hopefully have confidential conversations with their providers that might not have been possible before. So I think this is a positive change that will really enhance access to care. Adolescence is a critical time of growth and development when young people are establishing their identity and learning skills that they'll need to become independent adults. And learning to navigate healthcare effectively is one of those skills. And there are some concrete things that we can do to help promote this with adolescents. So providers should also be aware of really the growing diversity of the adolescent population. And I think the information on this slide really speaks for itself. We can really see from looking at this that today's adolescents are increasingly more diverse in terms of their race and ethnicity, their gender identity, and their sexual orientation. And so moving also to look at adolescent behaviors, some adolescents are having sex. About 40% of high school students report that they've ever had sex. Actually, compared with 30 years ago, teens today are reporting less sexual activity overall and less unprotected sex, which are all trends in a positive direction. The teen birth rate has also gone down significantly over the past 30 years. And we know that that really has a lot to do with better access to sexual and reproductive health care for young people. I will flag one number on this slide that hasn't changed or improved in the last 30 years, which is the number of adolescents using alcohol or drugs before sex. So that's certainly food for thought. Adolescents and young adults are still impacted pretty significantly by sexually transmitted infections. Young people age 13 to 24 make up 22% of all new HIV diagnoses in the United States. We know that young Black and Latinx men who have sex with men are disproportionately represented among those new HIV diagnoses. We also see that young people age 15 to 24 make up 45% of all new STI cases here in the United States. And despite these numbers, more than 90% of high school students tell us they've never been tested for HIV or STIs. So that's certainly an area for improvement. So thinking about adolescents' developmental needs and their sexual and reproductive healthcare needs, here are some best practices that we're going to talk about today for adolescent health services. And these are things that have been recommended by the CDC, the American Academy of Pediatrics, and other experts in adolescent health. And we think that these are the kinds of things that can make it easier for young people who might be at risk for MPV to access care. So of all the best practices in adolescent health, confidentiality may really be the most important. This, I think, is really the foundation of good adolescent care. And remember, in New York State, minor adolescents can give consent for sexual and reproductive health services, and they have the right to receive those services confidentially. So it's vital that all healthcare staff understand these laws related to adolescent confidentiality and consent, and that we're hopefully giving clear and consistent information about this to adolescents and parents. And here we have some different concrete ways to think through how we can really protect adolescents' confidentiality throughout their entire healthcare experience, from the waiting room to the visit with the provider to billing and pharmacy. So a best practice here is really that adolescents are able to have time alone with their medical provider at every visit. And we really have a lot of evidence that this makes a huge difference in how adolescents use healthcare. We know that teenagers who feel assured that their care is confidential are more likely to access healthcare. They're more likely to open up and talk with their provider about sensitive topics like sexuality, mental health, substance use, and they're more likely to come back for follow-up. And this is really critical for populations, especially like young men who have sex with men and other youth who may be at risk for MPV. We know that 30 to 40% of homeless youth, for example, identify as LGBTQ, and that LGBTQ youth are anywhere from 4 to 13 times more likely to be homeless than their heterosexual peers. So, the stakes can be really high for these young people if they're outed to their families. And you can see how this could present an enormous barrier to care. And that's why it's so important to have this kind of environment where young people who are at risk can feel that they can speak openly with their healthcare provider about MPV and what options might be available to them. So there are some limits to confidentiality, and I think there's a couple of ways that this can happen, or a couple of types of limits. So one is where there might need to be an intentional disclosure, and this is something that can happen when a patient's safety is involved. It's also important to acknowledge to adolescents that health systems are not perfect and that there can be unintentional disclosures as well. So I think when we're, first of all, explaining the limits related to safety, I think it can be helpful with the adolescent to frame this in terms of caring about their well-being, rather than talking about it in terms of having to report something or report the adolescent, which I think is how the adolescent often understands that term, that they're being reported. And so an example of this is maybe saying something like, I hope you would discuss something like feeling suicidal with me, because, that's pretty serious stuff. And I would want to help you, and I would want to get other people to help you too. Moving on a little bit to talk about the unintentional disclosures that can happen. We already have kind of heard a little bit about the MPV vaccine and how that's handled in vaccination records. So minors can self-consent now for the vaccine, but there's currently no way to hide that from their vaccine record. And so their parent could find out that way by requesting a copy of their immunization registry. I also want to flag here that there are a lot of challenges with electronic health records, and the 21st Century Cures Act has made that more challenging recently. Many institutions are currently working on ways to segment or separate confidential or sensitive information from non-confidential information in the electronic health records for adolescents. My best recommendation is to find out your institution's policies so you can have a transparent discussion with your adolescent patients about what they can expect. So moving on to some more best practices in adolescent health, it's really important that everyone in an office or a health center is welcome and welcoming, non-judgmental, and trained to work with adolescents, and hopefully focusing on their strengths instead of seeing adolescents as a problem, which is sometimes what happens. So good adolescent care should be culturally competent. It should be racially equitable. It should be welcoming to LGBTQ youth. Adolescents should be able to access care in the language they speak. And good adolescent care should be welcoming to young men. Young men often may not feel included in services that are sometimes focused a lot on contraception. Some institutions in response to that have started young men's clinics in order to create spaces where young men see themselves represented and feel comfortable seeking care. And again, here, young people who might be at risk for MPV, they really need to know that they're going to be treated respectfully and non-judgmentally in your office or your health center before they even think about bringing this up with you. I also encourage providers to adopt a reproductive justice framework. Many people have experienced bias and disparities in sexual and reproductive health care. In particular, people of color, teenagers, immigrants, people experiencing poverty or homelessness, and LGBTQ people are among those who might experience bias or judgment from healthcare providers, especially related to their sexuality, their sexual behaviors, or their reproductive health decisions. The Reproductive Justice Framework, which was developed by organizations representing women of color, including Sister Song and Forward Together, asserts several basic rights of all people. They assert the right of all people to maintain personal bodily integrity, the right to have children, the right to not have children, and the right to parent children in safe and sustainable communities. Remember also that some people have experienced sexual trauma, and so taking a trauma-informed approach with all of our patients really is also another way to help honor people's rights to their own bodies. So another best practice in adolescent health is providing comprehensive services. So like many people, adolescents can find it challenging to navigate healthcare systems. This is certainly not just true for teenagers, but they might be more likely to seek care in a multidisciplinary setting where everything is available under one roof and people don't know, why they're walking in the door. This kind of integrated care can be especially important, again, for young men who might be more likely to seek sexual health care or go for counseling at a center where they feel that they can tell their friends they're just going for a sports physical or some shots for school. Sometimes also offering school-based or school-linked services is another way to help young people access care. In New York City, there are school-based health centers. There's the CATCH program and the New York City Teens Connection, which all work in schools to connect teens to care. You may want to consider asking your adolescent patients if they know if there are any health services available in their school, and then try to coordinate that care where you can. Another best practice is to offer sexual and reproductive health care to adolescents. So remember, again, in New York State, minors don't need a parent's consent for these services. And it's good to have a clear and consistent message about this from everyone on the healthcare team. So another best practice is easy access to care. So this is a graphic from the American Academy of Pediatrics. This is outlining all the steps that an adolescent might have to take to get to a medical appointment. So here's my thought exercise, and I'm going to call on you, Dr. Heslin. Think back to when you were 16. And now imagine what it would be like for your 16-year-old self to do this, to go through all these steps.
It's pretty tough. I have to say, I barely had a learner's permit, never mind knew how to get from point A to point B. And navigating all of this, I don't think I even knew I had health insurance until I was probably in college and I was mandated to have it. So to just look at 19 different things you have to do to navigate a system is complex and costly. And we should be able to figure out how to do it better.
Exactly. And so now, even as we all reflect on our 16-year-old selves, now imagine if, our 16-year-old self is somebody who, might be at risk for MPV and, wants to have that conversation with a provider, and how daunting that would be. So next slide, please. So the next slide is going to share some really concrete things that can help a lot of adolescents, make it easier for them to access care. I want to highlight the family planning benefit program here as an option that can be great for a lot of adolescents, especially if they have commercial insurance, because it can be a way for them to have confidential services paid for without an explanation of benefits going to their house. Also, phone numbers change a lot, and this is especially true for adolescents. Be sure to confirm or update confidential contact information every time you see an adolescent. And I would even say, this is just my personal bias, consider notifying adolescent patients about all of their results. I think a lot of us practice a no news is good news kind of policy. I'll just call you if there's a problem. And I have spoken with a lot of adolescents who said, I went and got tested. I don't know what my results are. No one ever called me. So I hope that's a good sign, but they're not really sure. So I think if we can normalize adolescents knowing their test results, positive or negative, that's a good thing. Okay, so where are parents in all of this? What do you think, Dr. Heslin? Do you think parents are feeling a little left out at this point? Is that possible?
As a parent, I would feel left out.
So the intention here is really not to leave parents out, and parents are extremely important in their adolescents' lives. They're extremely important to their adolescents, and I think sometimes parents don't feel that way with teens. I heard an adolescent medicine specialist once say, never tell a parent that you're kicking them out of the room, and never even in a right to have a confidential conversation, and never even think this in your mind, because that's not what we're trying to do here. What we are trying to do is empower adolescents to have private space with their provider. And I think also with young people and their families, we can also frame this in terms of helping the adolescents learn skills that they're going to need to transition to adult care, right? To be able to manage their own health. At the same time that we're empowering adolescents to have more privacy and also more responsibility in healthcare, we should also be encouraging them to discuss health with their parents. Sometimes my experience is that adolescents actually really want to discuss concerns with their parents, and they're just not sure how to get the conversation started, or maybe they feel a little timid. They'd like some extra support with that. That's a situation where you as a medical provider can offer to speak with the teen and the parent together. If of course, if the adolescent is comfortable with that approach, that can be really helpful. And I think also it's really vital that we're always giving parents the message that they matter very much. They're extremely important in their adolescents' lives, and offer them some supportive resources. I will call out an excellent website for parent communication with teens. It's parentandteen.com. It's from the Children's Hospital of Philadelphia. So the final best practice that I'm going to talk about today is just a natural development from the last topic, supporting adolescents transitioning to adult health care. It is considered a best practice for providers to develop an adolescent transition policy and start working with young people and their families as early as the age of, kind of 12, 13, 14, to have a plan for young people to start to learn the skills that they need to manage their own care. And if you're looking for more information, gottransition.org is a nationally recognized resource for best practices in transitions to adult health care. So the next couple of slides are sharing some of the references and resources from this part of the talk. And I will go ahead and turn it back to Dr. Heslin.
Oh, thank you very much. If you can go to the next series of slides. Thank you, Michael. These are resources that we've put together for accessing monkeypox vaccine and care. It's important to note that New York City Health Department sexual health clinics provide care to minors 12 and older, and parental consent is not required. I think that's probably the most important thing on this slide. Go to the next slide, please. The eligibility to receive monkeypox vaccine is the same throughout New York City and New York State. Known or suspected exposure to someone with monkeypox in preceding 14 days, and high risk for recent exposure, which basically means that anybody can get a monkeypox vaccine if they think they're in a risk category. And the eligibility gets updated fairly regularly. And for New York State, there's monkeypox vaccination hot link. And for New York City, it's monkeypox MPV vaccination-eligibility. And all of these links are active. And you can get this webinar off of the New York State website under monkeypox. Where to get vaccinated outside of New York City, check with your local health departments. We have been running campaigns through local health departments and with their partners, both hospitals and clinics. The AIDS Institute is running a pilot with a number of organizations throughout New York State to make sure that there's equitable access. And in New York City, vaccinefinder.nyc.gov, or you can call the number. In terms of accessing treatment, really in New York State, outside of New York City, there is just we're seeing maybe 10 cases for our roughly 12 million people a week. It's a really small number. And so we have a healthcare provider network that is set up with infectious disease specialists and larger regional centers to make sure that there's the appropriate expertise available to make sure that you're getting good information. And in New York City, they have a much larger cadre of people that are providing treatment options at this time. And you can access that through the provider information on the screen. I will point out that an excellent option for people in New York City to go to Health and Hospitals Express Care, which is a virtual visit that can be done for you, and you can work through that system. It's a wonderful resource that's available. Finally, resources that are available both through New York State, New York City, and the CDC regarding monkeypox. Thankfully, we have seen a decline in this across the entire state, yet we have not eradicated this yet. It's really important to recognize all the different cohorts of people that could end up with monkeypox. I really have to thank Dr. Larkin today because, I've got a 7-year-old at home. She's not quite a teen yet, but she thinks she's a 25-year-old. And so what she brought to the table today in terms of the discussion is important. We need to be open about these discussions. We need to be informed about these discussions, and we need to empower our patients to be able to connect to these type of services to make sure that everyone in New York is treated in a fair, honorable, and equitable way. I very much appreciate Dr. Larkin and Ms. Geisbond's presentations. And again, to all of you who join us during your busy days and lunch times, we very much appreciate your participation. We will likely be doing another one of these webinars in another month or so, or as needed if urgent updates need to be completed. Once again, thank you and have a good rest of your day.